the statement of my problem here for the presentation is that we've got this new pandemic going on, and occupational hygienists have a large toolbox of methods to prevent injury to workers, but we don't necessarily have a lot of training in infectious disease transmission and control. We do biosafety mostly for laboratories, and unless you've worked in a hospital or healthcare settings, you might not work too much with infectious agents. Yet workers are exposed to a broad variety of infectious agents. So my talk today is to review basic characteristics of infectious agents and disease transmission, and then talk about some possible occupational hygiene principles that we can use to control the spread in the workplace. So I always like to go back to 15 years ago. Dr. Lee Jong-wook at the WHO, the Director General, said it's just a matter of time till we have a world health pandemic. And he was talking about influenza, but here we have COVID-19. And it won't be the end. I hear people talk about this as the 100-year pandemic, but we've been having these regional epidemics for quite a while now, and this isn't necessarily going to end with COVID-19. It's been known for several years that infectious diseases is the leading cause of death worldwide for people under 45 years. And this statistic may change from time to time. It goes up and down, but it's pretty much obvious that infectious disease kills a lot of people. We don't necessarily think about this as much in very developed countries, but it is still a huge global problem. And it's not just in the community. We see that 9% of occupational fatalities are infectious agents. And in developing countries, that ratio is as high as 30%. People dying of communicable diseases from occupational exposures. And then Dr. Owumi mentioned this hospital-acquired infections. This is something, if you work in healthcare, we're very familiar with. Up to 25% of patients, depending on what statistics you look at, that go into the hospital acquire an infection while they're in there. So, you know, we're very familiar with the spread of these agents within a hospital setting, and how they move around from patient to patient and worker to patient and patient to worker. And recently, we've seen for COVID-19 this short snapshot of exposures from February 12th to April 9th of the number of cases of COVID-19, about 46,000, and the percentage of those that are healthcare personnel. And this graph pretty much shows it's about 20%. About 20% of the COVID cases in this block of time were healthcare personnel. And of course, healthcare personnel do not make up 20% of our population. So here's a demographic, and this will be coming into play more and more in the near future. If we look at this number of cases of COVID-19 in healthcare personnel, about 9,000 in the same time frame, when they trace back their exposure to where they got their COVID, it comes out to about 55%. 55% of the cases came from their workplace exposure. 27% came from someone else in their household, and only 13% came from the community, and 5% were unknown. But this goes to show that these are occupational exposures that their employers are not controlling. Now, we will get into things that what is a community exposure? Is your household exposure is a community exposure, but we're going to be debating this more and more in the near future. Is a meat processing plant an occupational exposure, or is that a community exposure? So just as a quick review, if you haven't looked at these for a while, but the basic microorganisms we're talking about: bacteria, viruses, protozoa, fungi, prions, and elements. So we can start to think maybe from university, the one semester of microbiology we took, we might recall some of these. And I like to point out that each one of these has their own characteristics, and there's hundreds of different types of each one of these that we can analyze. And I'm going to talk about a little bit further here, but I put in the size there, just from the smallest virus to the largest bacteria, about 0.01 to 10 microns. So I mentioned all the varieties of industries where people get exposed, from healthcare to agriculture, forestry, veterinary, livestock, meat processing, law enforcement and corrections officers, nursing homes, and mining. From what I understand, there's a large amount of tuberculosis in South Africa, in mining workers, and along with that, HIV. So there's a workplace where we're dealing with that they recognize a problem at this time. Again, very basic, going back to the chain of infection. And for occupational hygienists, we think about a workplace, a chemical, or an agent. We don't necessarily think about your colleague or the person standing next to you. Some of these reservoirs are a little bit more obscure. We might think about Legionella in the air conditioning system, but then we also move to the chain of infection and mode of transmission. And I like to call it pathway of transmission in industrial hygiene, but in healthcare, they'll use the term mode of transmission, and they're a little bit different. We don't typically talk about mosquito bites as a vector in occupational hygiene, but we could. We have workers that could get malaria, and working in the fields can get malaria. But we also have these direct contact, droplet, airborne, and the vehicle there, such as food, but that could also include the water system or water treatment. And then it moves over and it's going to hit our susceptible host. And I call these routes of entry, but in healthcare, again, they call them portals of entry. So inhalation, ingestion, injection, and a dermal pathway, to name a few. Well, they did put this together in a paper by Islami, a recent paper, and they made this same type of visual up for the purpose of demonstration. They showed here on the bottom left, they've decided now that it's not transmitted through insects. We've got the droplet precautions, 2 to 3 feet, and potentially aerosol exposure at 6 feet. They bring in the fact of how temperature or humidity can affect the virus in the environment, and the fact that the surfaces can become contaminated. And then it's transmitted to a worker or a person. So we have the routes of exposure: inhalation, ingestion, mucous membranes, intact skin, and puncture with injection and open wounds. So those could be pathways for COVID. And then a new term for occupational hygienists that we really don't think about too much is the portals of exit. So this is, where does it come out of a patient or a person? If we think about a colleague, where can it come out of a colleague? In respiratory passages. It has been noted in feces now, COVID-19, and then other genitourinary systems, skin lesions, and blood. And I haven't seen anything about blood for COVID yet, but we have to think in terms of the people we're going to be exposed to. So one of the things that's coming up a lot now is how to control this and why we need to control it. And there is some literature out on COVID and the duration that it can live from potentially 3 hours in air up to 3 days on certain surfaces. But if we're going to expand our knowledge in occupational hygiene and be able to address these issues in the future and expand our rubrics into biosafety or infectious disease control, we need to really look at each one of these. And each type of agent is different, and it's got a different persistence in the environment, from a few hours and a few minutes to months. Something can live someplace. So everything's different. And partly when we're thinking about cleaning and disinfection, we really need to think about, do we need to clean the floor? Do we need to clean the ceiling? If it only lives for 3 days, who's going to touch the ceiling? So we need to put these factors into how we might make decisions about control. The other things that we need to consider about control, and these are terms we might not use in occupational hygiene very often unless you're in healthcare, is infectivity, pathogenicity, virulence, this environmental transmissibility, and incubation and infectious periods. So I'm going to just quickly talk about these and try and explain why we need to think about these. But infectivity, the basic definition, is the propensity for transmission. How easy does it get around? And it's measured by the secondary attack rate. And it's basically, can you catch it in your home? Can you catch it from a family member? In very basic terms. And it's just a measure of the ability for this agent to move from one person to another, regardless of the pathway. Pathogenicity and virulence are terms that are easily mushed together, merged together. Pathogenicity simply is the potential for an agent to cause disease, and it's measured by infection ratios. Virulence, on the other hand, is a little bit more specific. It's the ability of this agent to cause severe disease, and it's measured by case fatality ratio. So there's a lot of space in between those terms, pathogenicity and virulence. Virulence can be characterized by how much it takes to make you sick, the infectious dose, the portal of entry, the ability to multiply in the body, and the ability to avoid host defenses. And sometimes that means its ability to mutate to avoid host defenses. So it gets pretty sophisticated when we're trying to compare virulence. Pathogenicity might be different in different countries for reasons maybe such as one country uses a vaccine and has access to a vaccine and one country doesn't. So it would be easier to spread and cause disease. Virulence could be affected by the medical system or the likelihood to get treatment. So as occupational hygienists, maybe people in general, we like to classify things. So even though we have hundreds of agents and viri and viruses and bacteria in different levels, we like to know how bad it is. So we have the World Health Organization, the National Institute of Health in the US, and then the European Union. And we kind of came up with these groups, 1, 2, 3, and 4, 1 being safer and 4 being extremely dangerous, to try and tell people how bad this new agent is or how likely it is to spread. So you can kind of use these and look at where diseases fall, going from isn't likely to cause disease to might cause disease, but it's not transmissible, to might cause disease, but we have medicines that can treat it, to the very worst is that it's easily transmissible, it's very virulent, and we have no medical treatment. And then the range in between agents is quite complex to try and define one, but we try and do it. So here's where they have done it. The NIH and the European Union have put some categories on these. And we can just kind of see Ebola is 4 or Marburg virus is 4, but then we come down to West Nile virus, it's 3. And here we have coronavirus is a 3. You could argue why isn't that a 4? But you know, there's probably other factors that they use before they go into this. But it's what they use. Rabies is 2. I mean, I guess if you got rabies, there is a cure if you take it right away. The other thing we want to think about in terms of infectious dose. So we know some of these, and these, I'm not sure who published these or when they were, but you know, they came up with an infectious dose for measles, which is very transmissible, but you also don't need much of a dose, 1 virus, to get measles. Where, you know, we get down to plague, maybe you need 500 cells from a flea bite. So you can kind of see, and you know, in occupational hygiene, we have threshold limit values or levels that we think are safe for worker exposure. And we have methods to go measure those in the workplace. for infectious disease, we not only don't really have a good handle on infectious dose, we also don't have sophisticated measurement methods to be able to quantify these in the workplace. So we're behind the 8 ball with this concept of how we typically control things. And then I mentioned this concept of incubation and infection, and we've seen this play out now with COVID-19, that you don't necessarily have to have symptoms to be infectious. And it's important to understand what that incubation period is, what the symptoms are, and when it might be infectious. And the bottom part of this chart here, we've got different agents. So keep in mind, there's a range of when this occurs for each person. So no one's the same. And then there's a range of incubation and infection for each agent. And remember, there's hundreds of agents. So in occupational hygiene, we have a responsibility to know these. And I think about someone that's going to send a worker over to Africa to work on an oil platform off of the coast of Western Africa. You, as the occupational hygienist, need to think, what shots do they need to take before they go? And do they need to have malaria medication before they go? And where is their route going to take them? And what infectious agents are they going to encounter on the workplace? So we have to think really outside the box. So moving on, the second half of this presentation, and I apologize if I appear that I'm going very quickly, but you should be able to access these slides and look at them later, and anyone can contact me and ask questions. But we're going to skip elimination and substitution because that's a kind of a theoretical approach when we're talking about infectious disease, and I don't have time to go into that. But we know we do ventilation. We're not quite used to disinfection, sterilization. Now we hear about ultraviolet radiation being used, fumigation, safety devices, and waste handling. These are kind of things that go into infection control in the workplace that occupational hygienists can bring. The main point here is that many of these controls that people want to use are also toxic or hazardous or carcinogenic. So when we're advocating for cleaning things or fumigating a room or something, we need to be the ones there to say, wait a minute, that might not be safe. We're going to start using ultraviolet radiation to disinfect subway cars. We need to be there to be the voice of wisdom to say, how are you going to protect the workers? Ultraviolet radiation is a class 1 carcinogen. And then we might be able to help them handle waste also. That's part of what we do in hazardous material management. And then even safety devices. In healthcare, we get involved in helping pick safety and safe needle and safe sharps devices and tracking and trending and reporting those as OSH log injuries. So we have administrative controls, testing, training, screening of patients. This is pretty new for occupational hygienists to be getting involved in. But again, we are good at writing programs, procedures. Following those WHO guidelines is a great place to start. Doing inspections, audits, and reviews. And I think a lot is going to be falling out here shortly on what we're allowed to do, taking temperatures, collecting data on personal medical information is going to be very interesting shortly moving forward. And then ultimately, we always have a role on training. What are the hazards? How do you control this infectious agent? We notice COVID is in feces, so they've seen it in measurements in hospital bathrooms when people flush the toilet. Maybe we should have lids on our toilets in the workplace and have people putting the lids down. But these are things it might take a mindset change, but we should be the ones leading the march here. And then again, PPE, donning and doffing, and training the workers on how to do this appropriately and effectively. And then using PPE. And of course, PPE is the last resort for protecting workers. And just a set here of things that the ultimate PPE. When the SARS outbreak started in 2002 in Toronto in 2003, they started wearing a surgical mask and no protection, bare arms and, gloves. And they ended up wearing something that looked very much like this over a period of about 6 weeks. So things are always in transition. Infectious agents often seem to be in transition, and workers get confused. So that's something we can live with. We're just going to have to deal with that. Even we see the CDC and the WHO changing their mind on a nearly daily basis. That's okay. Sometimes it appears the agents seem to change. I remember when H5N1 came out of Mexico, it seemed very virulent in Mexico for some reason, but by the time it got to the case fatality rate went way, way, way down in comparison to Mexico. So there's a lot of factors that go into infectious diseases. So we have a lot of tools to be used to provide effective control and protection of workers, but we need our members, our colleagues to understand these basic characteristics of infectious disease and agents in order to apply those controls effectively. So thank you for listening.